Well, thank you, Sung Ho, and the organizers for inviting me again to come to this conference. It's been wonderful to come to Korea and see old friends, and each time I just see that there's more people in the room. Anyway, so today I'm actually doing the second half of the complications lecture compared to last year. Last year I talked about part 1, which was about the general principles of what to pay attention to in the cath lab. Part 2 is really focused on the interventions. Now, I've been collecting information for the last 20 years on this topic, complications, and hopefully one of these days this will become a book. So many of the information and the pictures you will hopefully will see in a book soon. And it's a book that I've been writing for a long time, and I have never been able to complete it, probably because there's so many complications that we deal with. Anyways, so this lecture is really about interventions. All right, so I'm going to review a little about part 1. So generally, when I talk about cath, I have to get a consent from the family. And I usually talk about the big 6, meaning that these are the 6 most important complications to think about and to transmit, to communicate to the families. So number 1, of course, is death. It's very unlikely, but I always will say that that is one of the complications. Arrhythmias and heart blocks is another one of these big 6. That can be from surgical, from due to poor hemodynamics. It could be a congenital type of arrhythmia that is catheter-induced. The third thing is thromboembolic events, developing blood clots in the heart, and especially talking about the risk of stroke. Obviously, we prevent that by using heparin, but it's never a 0% risk. Another complication is bleeding, which could either from the groin getting a hematoma, or it could be internal, anywhere along the course of the catheter to the heart. The fourth thing is infection, because you're breaking the skin to get into the blood vessel, so therefore sterility is really important, especially when you implant a device. And the last of the big 6 is any type of cardiovascular perforations, dissections, or tears that can happen during the course of your intervention. So I say these 6 things all the time. Of course, I also add the complications specific to the intervention that I'm doing. So I always say start with the 6 and then add the different complications that is specific to what we plan to do, whether it's a valvuloplasty or angioplasty or device implant. So some of the more general principles I always talk about, especially when I talk to the fellows, is that the complications can be related to the anatomy of the patient, or the physiology, or the patient profile. What I mean by that is that you can deal with a premature baby, which have its own set of complications that is different from, let's say, an 80-year-old patient, right? For the babies, temperature is really important. So if you don't pay attention to temperature and give cold saline, that can affect the premature baby. At the same time, when you have an adult patient at your cathing, you have to think about all the comorbidities like diabetes, hypertension, carotid disease, things of that nature. So the patient profile is important, so that's why you have to understand that. We also want to warn our fellows that we have to think about the complications that we most commonly overlook. And these are things that you don't think about, but we overlook it, such as where the ET tube is. Are you right main stem, for example? Things that you don't think about that may not be particular to the cath, but you overlook it. Okay, so here's my philosophy. You have to prepare for the unexpected. You have to prepare for the worst. So every time you do a cath, you have to think about what's the worst thing that can happen before you start the case. You always have to anticipate problems. You always have the plan B to bail yourself out. This is when your surgeon can be your best friend. Unless he doesn't support your cath, then you're in trouble. You have to think about post-cath complications. Even after the procedure's done, you still have to think about things that can happen afterwards. How about extubation? How about reactive airway disease? How about pulmonary hypertension? So, etc. Major complications usually start with a small adverse event. It usually escalates with poor judgment. So again, not every complication is catastrophic. It starts off small, and when you start to make a series of mistakes, then it becomes large. So the thing is to stop yourself from making the bigger mistakes over time. So let's talk about angioplasty. This is in the part 2 now. So here's an example of a stent in the PA, in the left PA. So here we're going to balloon it. So what do you have to think about when you inflate the balloon there? Again, feel free to answer, because this is meant as interactive. I know that we only have 30 minutes. So we balloon it, and so what do you see? All right, you can say it out loud. You see a vascular tear here. When you see that, what's the first thing you should be thinking about? This is what I always think about. Is it contained or uncontained? If it's contained, I don't worry. If it's uncontained, then I better scramble. So the first thing you see this is that, is this well localized? Is it spreading anywhere? If it's not spreading, then you know you're fine. So what do you do with it? Nothing. It'll go away over time. Here's another example where you see a proximal LP stenosis. We balloon it. And what's wrong with this picture? You see it? See the problem? You see there is a dissection. There's an intimal dissection. There's a contained pseudoaneurysm. What can you do about that? Well, you can actually now put a stent in because it's a dissection of the intima. You can tack it back down and get rid of that. So that's another thing you can do. Here's another example of a patient with bilateral branch stenosis. It was a non-Williams type arteriopathy with multiple areas of stenosis. Now, this is actually belonged to one of my colleagues. And so, of course, we decide what kind of size balloon in here. And I remember him asking me, and I didn't think very hard. I didn't look at it very hard. I said, I'll just use an 8 millimeter balloon. So we did. Now, watch what happens to this balloon as it goes up. Okay, so anytime you see the balloon suddenly increase in size, you better worry because something is going wrong. Or if it doesn't, you're lucky. But anytime you watch that balloon, I'll play it one more time. If you see this movement of the balloon, it just pops like that. It usually means it's bad. So that's not a good sign if you see that. So be prepared, all right? So we take a picture, and what do you see? You see a dissection. Now you have a distal pseudoaneurysm. The problem there is that you can't tack it down because it's a small vessel, and if you put a stent there, you'll jail other vessels. But so what do you have to consider? Well, luckily, this area is stenotic. So you would leave the residual stenosis. Now is not the time to try to open this up. Leave the stenosis so that the pressure there stays low, and maybe with the low pressure, it'll heal itself. So at least you know that you're safe there. All right, so of course, we take an MRI 3 weeks later, and you'll notice that this aneurysm has gotten bigger. So that could happen. You hope it doesn't happen, but when that happens, now you have to consider doing something. In this case, it was measuring 20 by 8 millimeters. So we take the kid to the cath lab. Again, this is one of my colleagues, and we take a picture. And of course, in the course of trying to find that neck of the aneurysm, we pop through. And so now suddenly you have a hemothorax, and you have a disruption of the aneurysm. So now what do you do? If this happened to you, what would you do? You see all the blood flowing into the pleural space. You see the lung is collapsing down, and there's that blood in the hemothorax here. So now, what are you going to do? He gets hypotensive. Well, the first thing you can do a couple of things. You put a chest tube in, right? You can take the blood out and transfuse back into the body so you're not losing a lot of blood. Number two, you can take your catheter, inflate the balloon, and block the blood into the RPA. At least it's temporarily. Now you're stopping the blood from getting in there. So now you're controlling the bleeding with this wedge balloon catheter. You see the little circle here. That's the balloon catheter. And the next thing you do, we actually put a second wire in there to get a feel for what that area is. And we take a picture, and you'll notice this little dot right here. Right? This dot tells me that this is a neck of the entrance of the aneurysm. Once we identify that, now you can deal with it. Now remember, there's a principle in general surgery. When you have a bleeding in the GI, first of all, you manage the vital signs, resuscitate the patient. The second is to find the source of bleeding, and then you manage that, right? So in the same way, that principle can apply to interventions. You find the source of bleeding. Where is it located? So with that, we still have the wedge balloon. We're stopping the flow from in there. You're controlling the bleeding there. You notice that the hemothorax is gone because there's a chest tube, but you see this little neck. So the next thing to do is that we actually have a cath, and we actually put a coil in there to try to coil that neck. So this loop of coil is actually in the aneurysm, and part of it is now sitting on the outside with the dacron fibers holding onto the neck. You notice that this neck is very small, so you know that you can plug this up pretty easily. You just have to identify it. So here you put the coil in, and then actually this kid, 2 months later, we brought the kid back in. So this coil is actually in the aneurysm itself. You notice that here's the entrance into that aneurysm. There's no more, it's can stop the bleeding, and now you fix it. Now, of course, there's still a problem because you notice that the MPA is still systemic. There's still a large grade in the RPA because this area is still a problem. Now you can take care of this. So you bring the kid back, and now you can stent that, and that's basically what we end up doing. Opening that up, that's the pre and that's the post, and we actually got this back to less than half of systemic pressures. So that's how you deal with it. Always have a plan B in your head, plan how to do this. Now, here's the dilation of a big calcified conduit. This is from one of my mentors back in Texas Children's, and he let me borrow this slant. Look what happens to the calcium. When you see this much calcium and you inflate the ballooning, there's only two things that can happen. Either the calcium wins and you can't open it up and the balloon busts, or you win and you crack the calcium. I'd never want to win in this situation. So of course, when you rupture the conduit here, you take a picture and now you have to ask yourself, is this contained or uncontained? And I would think that most of you will say this is an uncontained tear. This kid goes to surgery. All right, so again, this is the kind of things you have to think through in your mind as you're doing these angioplasties. All right, let's talk about valvuloplasty. Here's a kid with critical AS, and this is done when I was a young faculty member. And you notice that here's my first inflation. All right, inflated, and the balloon waist goes away. I did my second inflation, and the the waist goes away. And then I take my picture, and there's tremendous amount of MR. So why? What happened? What did I do wrong here? You can easily go back to look at, here's the picture of the LV, here's the aortic valve, here's the first dilation, notice where the waist is. Is that where the level of the aortic valve is? No, it's probably by the mitral valve. Here's the second dilation, here's the waist. This is where it should have been, but I didn't pay attention to where the waist is. So anytime you do a valvuloplasty, you have to pay attention to where the level of the valve is, and you inflate slowly to see where the waist is, to make sure it's exactly where you want it to be. If you don't know where it is, you're in trouble, because this could be happening. So what I'd end up doing is tear the mitral valve, not knowing that this area was not where I should have been. Again, had I realized that the valve is up here, and I should have known that, I would have avoided that. All right, so that's why and you always have to remember to keep the fluoroscopy. Sometimes people would say, I did it exactly the way I was supposed to do it, and I don't know what happened. Well, if you don't save your fluoroscopy, you won't know what you did. So it's always a good thing to save everything that you do so that you can go back and review it and see what went wrong. You can always learn something from it. So I always save on my fluoroscopy. I know that doesn't happen too often. Another patient, aortic valve patient. Here's the cath, here's the EKG. This is one Texas Children, one of my colleagues. This is the EKG of the patient with AS. He proceeded to the cath lab. He does the aortic valve. His plan is to do aortic valvuloplasty of the aorta. If you saw that EKG, would you have any special preparations? I'll go back. So would you have any special preparations when you look at this? All right, don't talk yet. I see somebody already knowing the answer. But I'll just go through this. So he proceeded. And this is what happened during passage of the catheter into the heart. What do you see? Heart block, right? Complete heart block. So what do you do with that? Well, certainly he put a catheter in the right ventricle, paced the patient, and then started CPR, and he slowly recovered. Now you went from complete heart block to 2-to-1 heart block. Are you going to proceed with aortic valvuloplasty at this moment? What would you do? This skill has a lot of gradient there. You have to do something. Well, we know we dinged the AV valve there, right? So we create a heart block. I don't think it's worth the risk to do it again. You can always come back later on after you treated him, right? So the lesson here is that the EKG actually showed that there was a right bundle branch block. And of course, if you have a patient with right bundle branch block going to the cath lab for aortic dilation, you know you can also cause left bundle branch block. So if you cause that during the inflation, what happened? You have complete heart block. So anytime you have a right bundle branch block, you better be very careful with aortic dilations. Put pacing pads on just in case. Again, these are the things you have to think about. So go back to the EKG. You see the pure R wave here. That's the right bundle, right? But in fact, you see a left anterior hemi block. So what we end up doing is just get the third pathway out of the way, and once you block that, you're going to end up with complete heart block. So again, pay attention to your EKGs. Always review your EKGs before you start the procedure. Many times we always just think, let's go to the cath and just do whatever we have to do. We don't prepare adequately. So preparation can help you here. So have those pacing pads ready if you see something like this. It doesn't mean you don't go to the cath lab, but you have to be prepared. Here's another patient, newborn baby. This is a Texas Children's critical AS. You see the valve is very, the function is bad, a lot of MR. So this is Matt Christo putting a 4.5 balloon, inflated it well. That waist is where it should be. Second balloon looks really good. And here's what happens. Do you see anything wrong with that picture? Okay, you see the dissections here, right? Again, this is a newborn. He says everything was smooth. What happened? Well, I think a couple of things you have to pay attention to. First of all, just be aware that newborn babies have very fragile vessels. You don't have to feel resistance before you tear into it. But in fact, the biggest problem is the pigtail catheter, because look at this here, and I'll come to that. So here's the dissection. You can almost see the tear here and the dissection here. You see the dissection here, and then here on the internal lumen, you see the tear here. This is the pseudoaneurysm, and this is actually the vessel wall. So it's torn. So now this is another picture of another patient. This is 6-week-old, not even a newborn. But let me show you why that's important. This is a coarc dilation, but that's not the point of the slide. The point of the slide is look at the pigtail. How does the pigtail look to you when you see this in a 6-week-old new baby? Look at it. First of all, the loop of the pigtail is bigger than the vessel walls. It can't even fold back to itself. Now look at the tip of this catheter. It's sitting right up at the edge of this. So just picture a pigtail having a diameter much bigger than the vessel diameter. It can't fold back to its natural curve, and in fact, the tip of this can scratch the intima to cause the dissection, even though it doesn't seem like it happened. In a newborn baby, that could be very fragile. Here's the other part of it. This is post. But see, look at the diameter of this loop. This loop is way bigger than, let's say, this area or this area. In fact, a lot of times when you take a picture with aorta, don't you notice the pigtail causes the vessel to expand further because it's pushing against the edges? That tells you that that pigtail diameter is much bigger than what you need. So you got to be really careful with those pigtails, especially when you pull the wire back and it reforms that hook. That hook can actually scratch the intima. So you have to pay attention to that in the small babies. So the catheter tip can traumatize the vessels because the pigtail loop diameter is bigger than the aortic diameter. So be aware of that. All right, so of course, in the small babies, you can always do a carotid cut down. You don't have to come in from below. We didn't even talk about the femoral artery complications in the newborn. So if you come up from above, this is 800 grammer with critical AS. We come in from below, and you can see that we actually balloon from the top, from the neck. You don't have to worry about the arch, and therefore you can actually avoid those dissections in the newborn, especially in left heart interventions. All right, let's go to the pulmonary side. Here's a baby with severe PS with very dysplastic pulmonary valves. You can see that here. You can see that here. And of course, we ballooned with a 16. That was a 12 millimeter annulus. So 16 is actually a pretty good size. Again, this is when I was a young attending, being very foolish. I had a 20 millimeter gradient. I wanted to be perfect, so I said I need a bigger balloon. So I put an 18 millimeter balloon in. And again, watch how this pops at the very end. See, he's moving already, and I should have been aware that this was probably a problem, and this is the picture afterwards. All right, so I perforated, I tore the outflow tract. He went to surgery, and he passed away. And again, I feel that was my fault because I used the balloon that was too big. So again, the point is know when to stop. Know what your ratios ought to be. I just used clearly too big of a balloon in this specific situation, and that was my error. Okay, let's talk about device embolizations. So this is talking about stents first. There should be a general algorithm on how do you deal with stent that embolizes. First of all, we know that stents are stiff devices. They have sharp edges, and they are not error-friendly as compared to the occlusion devices. So don't think all devices are equal. Stents are not the same as the occluders. Stents are not designed to be repositioned or retrieved if it's not in a good position. So you have to get it into a good position first time. You have one chance to have a good result. So don't rush. Small details are important for optimal positioning. Give additional heparin if the stent is not in good position. Stay calm, you think, and you find out a bailout strategy. So always maintain good wire position. Never lose that. You lose that, you lose. So you got to make sure the wire's position is good. First of all, if the stent is not in good position, the first thing to think about is can I reposition it back into a good position? If you cannot do that, then you want to implant a stent into a safe position. It doesn't do any good, it doesn't do any harm, but at least it's safe, and now you can go back to deal with the stenosis. If you cannot put it into a safe position, now you're stuck. Now you have, okay, so what are the safe positions? You can put it in the IVC, you can put it in the descending aorta, you can put it in the contralateral pulmonary arteries. If you cannot put it in a safe position, then you have to remove it. And you can only do it by catheter, or you call your favorite surgeon to help out. And again, make sure you get support ahead of time, right, Rick? Okay. So here's an example of a stent that was not in good position. It's inflated. Here's a residual stenosis. And watch what happens carefully. As we inflate the balloon, watch what happens. Did you see that? Now again, I always tell my fellows, inflate slowly. Don't inflate fast, because if you inflate slowly, you have time to adjust. Did you see what just happened? As the balloon was inflating, watch here, it jumps forward. Right there. See it? Watch the arrow. This is before. Now suddenly it jumps right there. That's not a good sign. So if you can do that, now if you see that, again, you can only recognize this and react if the balloon is inflated slowly. If you go fast, you don't even have the time to react. So of course, when you do that, you can now pull it back. And again, you have to be very careful. I put the sheath up again so it doesn't pop too fast. Now I pulled it back to where I was. Now this arrow is just to show you where the stenosis needed to be. And then you can slowly inflate it. Now by doing that, you reposition the stent, and now you can see that you are able to get yourself out of trouble. But if you push fast, you won't be able to save yourself because you don't have time to react. Here's another example of a coarct in two spites. Here's a stent that went up, and here's the second stent. Well, actually it didn't go up because it fell in here. We're not in a good position. So basically we end up try to put it into the second area, but we actually was able to secure it into a safe position. It wasn't where I wanted it to be, but at least it was safe. And so with that, we put a second stent in along the arch. So basically, you went and ballooned both of them, and so now you're able to, at least the embolized stent is in a safe position. And this is what it looks like. Now, of course, that same patient later on, it fell into the aorta. The proximal stent embolized. At least it's in a safe position. You take a picture, it's not blocking any flow. You can leave that alone. You go back in and put another stent in. So again, if you can't reposition it, put it into a safe position. Here is an example of a balloon rupture from a colleague of mine, one of my former fellows. So now you see what happened. Do you notice anything here with the arrows? The balloon is inflating, and the balloon ruptures, because look at the contrast, Paul Deuce. Now you suddenly have a balloon that cannot go up anymore because it's ruptured. The stent cannot be further dilated. Well, in the course of trying to adjust it, it malposed. So now, now the next thing is that it's not in a safe position. You're going to have to try to get it out. So here, he secured it with one snare, and then he put a second snare up. And you can see how the way to do this, you crimp that back down in a way that helps you to reposition. And with that, you can pull it back into the stent. So if you can't put it into safe position, you got to retrieve it. And if you can't do that, then you call your surgical colleagues to help. Make sure you call them early. Don't ask them last minute, because they will be upset if it's late in the day. Okay, let's talk about occlusion devices. Most occlusion devices, you know, are very flexible, very pliant, and can be retrieved easily. So these are very user-friendly devices. You can afford to make a mistake and still get in trouble. These include the ASD, the VSD occluders, the PDA occluders, all the different plugs and the coils. The key is to know where and how to grab the device and how to pull it into the sheath without damaging the heart and vessels. That's what you really have to learn how to do. You have to have a big arsenal of big sheaths, long and short, snares, grabbers, different kinds of bioptomes. Again, stay calm, you give some additional heparin, and you come up with a retrieval strategy. So I've shown this in the past with ASD device. It was a good position in a teenage girl. 6 weeks later is in the MPA. Actually, I said 24 hours. I think it was later than that. Anyways, not in a good position, so we went up there, we grabbed it, and we pulled it, and we couldn't pull it in. Well, what's wrong with this picture? I think you have to recognize that the sheath is kinking. The harder I pull, the more I create this. There's no way I can pull this back into the sheath. Why is that? Well, if you look very carefully, the neck of this device is on the outside of the sheath. There's no way that this can go into the sheath if it's on the outside. You need a larger surface area. And I know many of the senior guys here know how to deal with this. What you do is, actually you can see the clue here. We found a new sheath, and now we are able to pull it in. Well, what did we do to create this? Well, if you go back and look at it, here's actually a new device put in, and basically it was fine after that. But here's the tip. Here's the tip of the sheath that we did. What we did was that we made a bevel cut along the edge so that now this is what the cross-sectional area of the sheath is. But by making a bevel cut, you actually create a much larger opening for the device to come in. So typically, by just making a little give out, you can increase the size to allow this device to come in. So you do that ahead of time. Nice little trick to have in case you run into trouble. Another 12-year-old with a large device. This is a colleague of mine. This is also when I was in Houston. What do you do? So we basically end up putting a big device in. Looks pretty good. It's splayed around the aorta, and this was a pretty good result until it fell into the outflow tract right here. So now what do? It's not easy to pull a big device in. I think this was like a 32 millimeter. So put 16 French in and grabbed it, pulled it in, and for the life of us, every time we pull harder, the tricuspid valve will have a lot of regurgitation. But eventually, we got it down into most of it in. This part wouldn't come in, and because it was stuck in the outflow tract. You know how when you pull out the disc, this has to extend first before it can come in, and there was just no space for it to extend. So eventually, we're able to get it back into the IVC. And so here, you see we're pulling on it, and at this point, it doesn't come through. Well, we actually pulled a little harder than we wanted to, but we got it bound, and then we're able to pull it into the IVC. And at that point in time, you can see that the device actually had a cobra deformation. The blood pressures are more stable at this point, so what do? So at this point, you basically knew that if we let go of the device, it's going to be stable in the IVC because it's so big, and then just put in a larger sheath, 20 French sheath, and then you can pull it out. Luckily, it's in the vein, so we can get ourselves out of trouble. So make sure you have all size sheaths ready for you. Of course, you have to take pictures to make sure that there's no clots, no extravasations, et cetera, et cetera. And so you see that. We took pictures all over to make sure that there were no clots anywhere. So we dodged that bullet. So a word of caution. We oftentimes focus on how to implant devices, but we don't spend enough time to learn how to prevent and manage complications. That's why I think this is an important lesson for a lot of the junior faculty and the fellows. You have to learn how to retrieve embolized devices, you have to learn how to adjust malposed devices, and you have to learn how to prevent them. This is my secret to your interventional longevity. I know that when surgeons start out, if they have many complications, they won't have a job for very long. So the same thing, when you're an interventionist, you have a lot of complications, you won't be doing a lot of caths. So here's the secret to longevity for interventions. Become very familiar with how to use retrieval devices, because sooner or later you're going to get into trouble. So if you get familiar with these devices, you'll get better at it. So the skill and knowledge of how to learn to use this will help you get out of trouble. I remember as a fellow, not knowing this ahead of time, I would have a snare in my hand during conference because I would get bored and I would start practicing with my hands. So these are little things you can do to learn how to control the micromanage manipulations of the wires and the snares and so forth. So if you do that, you can save yourself, get yourself trouble, and become an interventionist for many years. Okay, another lesson. It's not over until it's over. Why do I say that? Here's an example. The stent is in good position. The person is very happy. What do you do next? You take out the balloon and take out the wire. You're done, right? Well, guess what? Without thinking too hard, he pulls the balloon grabs the stent and pulls the stent into the wrong position. So again, it's not over until everything is out, right? So always be on guard. So of course, this is a situation, you put a bigger balloon in, you capture the stent, because it's a Fontan, there are no valves, you bring it down to the IVC and you put it into a safe position as we chatted before. All right, so that's one way. Here's another example from a colleague of mine, Henry. So you see a stenosis here. By the way, all of ones, I have gotten permission from them to let me use the slides, okay? So you know that I didn't take it and secretly use it. So anyways, so another way of trying to save yourself is that if it's not in a good position, you can actually try to stabilize it. So in this case, you see here's the embolized stent, and basically he put a longer stent in. I think I was called in to help him with this, so the two of us was able to at least get back through that stent. Again, as long as you have the wire in position, you're safe. So you put the second stent in, you take your sheath and you push this against the outflow tract. So you notice the sheath is stabilizing that stent. Now you inflate it. So by doing that, what you're doing is that you're now, not only are you getting rid of the stenosis that's right here, but now the long stent is telescoped into the small stent and you're stabilizing. That's not going anywhere at this point. So by doing that, you're able to open everything up. Obviously, the trade-off is that you notice that it partially jails the RPA, but there's no obstruction of flow. So you're fine. You got yourself out of trouble for that. But that's another way of doing it, trying to stabilize it by using a second stent. The trick in pulling balloons out is that you notice how the edge of the sheath is. If you pull the balloon like this, you can imagine the wings of the balloon is gonna drag the stent out. So what you have to do is, so it's not over until the balloon is out and the wire is out and the sheath is out. What you do is you inflate the balloon. So you notice by inflating the balloon, you're centering the sheath away from the edge of the stent. And with that, as you deflate the balloon, you can advance the sheath. So now the sheath is inside the stent. Now you can bring the balloon into the sheath, and then the whole thing can come out without any risk of dragging the stent out with you. So that's another trick of making sure that you can get the balloon out safely. All right, here's a patient you've seen as a ductus, and I know that everyone's going to say, let's stent the ductus. We did that. That looks really, really good, right? We opened it up. We're happy with the results, right? Pretty happy with it, right? And now, there's no balloon here, so you just have to pull the wire out. What's easier than that, right? Just pull the wire out. Well, guess what? Wasn't that simple. What's wrong with this wire now? This is the thickness of the wire. This is what is happening. We're pulling and pulling. It's coming out, but nothing is moving here. What happened? We ended up putting too much of our torque on the wire there, so it's all stuck in the small vessel. So this whole part of the wire is stuck in the pulmonary. You're pulling the wire, and the wire is just connecting. It's breaking apart. And so this is what it looks like. This is the wire that has been torn apart. So eventually we got this out, and this was done surgically, but this can happen too. Again, it's not over until you get all the balloons, the wires, and the sheaths out. Just know that. It's not over even after it's over, because you're still responsible. Again, you've seen this, I'm sure all of us have seen devices embolize even after it looks good. You send the kid to the recovery room, they embolize, they go home, they come back embolize. So you see an ASD device in the left ventricle, in the outflow tract, in the aorta. So you can embolize anywhere. Now the good thing is that most of these can be retrieved. At least you got that. You can't get that so easily with stents. So every time you put a device in, just know that you can still get into trouble even afterwards. So PDA occlusion, what can be simpler than that? Here's a device from one of my colleagues, again in Houston, and looks pretty good. And this is are you happy with this procedure? So he was. So he went, and of course, in the operating room, he hear a continuous murmur, and suddenly you get an x-ray, the device is now in the aorta. Okay, so with that, he brought the kid back to the cath lab, went the cath back through the PDA down, and you can see he used a bioptome to grab that device. And luckily, because of the position, you can actually pull that all the way in pretty easily. And now you can drag the whole thing in. Now, in fact, you don't have to drag it all the way in. You can actually reposition it here. So now again, putting in here, this is where the stenosis is, and then pulled it back some more, and with this he was happy, he releases it, and that's what it should look like. Now let's go back and look at the comparisons. Here's the initial position of the PDA device, here's the first adjustment, here's the second adjustment. What's really important is that if you use this as the anterior tracheal edge, this is where the first device position is. Here's the second, here's the final. It's much further away. Now, the reason why that's important is that you have to have a piece of the device in the PAs, right? If you leave it all in the ductus, there's a risk of fall back. So you got to know where those areas are. You got to pay attention to anatomy. And we're talking about a few millimeters. So here's the first device, and here's the second. If you look at the arrows here, this is where the pulmonary entrance is. Here's the pulmonary entrance. Here, the device is not even in the pulmonary side. It's still all in the ductus. You can imagine this can easily fall back in. So you got to get a piece of that device onto the other side where you have it in the MPA. Again, we're talking about a few millimeters difference, but those few millimeters can impact the outcome. So again, pay attention to millimeters. You got to be really detailed with the small details. Another one, this is from a colleague of mine. This was from one of the eye fluid cases at Sky. Sometimes if a bioptome, if a snare doesn't work, bioptome tend to work very well. So you make sure you have those two available to you, snares and bioptomes. They can use to help you retrieve devices. X-Premi, 6-month-old device put in right here, looks pretty good. Again, in a place where you have fellows, what do? We tell the fellows to look at the x-ray, right? Of course, the fellow tells Dr. Justino, everything looks good. He goes home. The kid sat in there for a few days, and finally time to discharge, get an echo at discharge, and this is what it looks like. The device had embolized, is sitting in the outflow tract. It's been sitting there for a week because nobody bothered to look at the x-ray because the fellow said it was good. So the lesson is, Don't listen to your fellows. All right, so this is the X-ray. Where is the device? Actually, you can imagine this might be in the right place if it was up here, right? Here's the bronchus. The ASD is somewhere up here. The fellow thought this was good. We went back and looked at this, and we said, we knew this right away, except the attending never looked at the X-ray. So always check yourself. Don't rely on your fellows, because you'll get into trouble. Nothing bad about the fellows, but always check yourself. All right, so here's another patient. This is my fault now. So I'm talking about my colleague, but this is me. Saturation, this is a CHLA. So we do the stent, and it looks good. Again, it was late in the day. My fellow says, X-ray looks good. I went home. Saturation is low, and I won't even tell you which fellow. What do you do now? So this is where the stent was. This is supposed to be a ductal stent. Again, the fellow just didn't know where it was supposed to be. Again, this is my mistake, right? Because I didn't look at the X-ray before I went home. All right, so it's not over until it's over. So check your X-rays afterwards yourself. Okay, so here's another example of a stent going out in the outflow tract. And 2 months later, I see him in clinic, and guess what? Everything is fractured. He had a basketball hit him in the chest, and it just pushed the sternum enough to cause a fracture. Now, luckily in this case, everything was patent, even though it blocked some of the vessel. And in fact, 10 years later, we did this again, and it was fine. So we were lucky. But again, it's not over even after it's over. Things can go wrong even after the patient goes home. All right, so here's another example, Melody valve, looks good, and you can see how there's a fracture here. And this happened later on. So again, it's not over even after it's over, because things can go wrong even years afterwards. So more anticipation. You know your adjacent anatomy, have to have a high index of suspicion for potential obstruction of adjacent vessels, understand the importance of borders and landmarks of the cardiac structures, be aware of potential impingements, erosions, dissections by the devices. So just transeptal puncture, you notice that this injection, the contrast is not in the right place. Where is it? We put a pigtail here, and we notice that it's right in the aorta. Good thing I didn't keep pushing, right? You take a little picture, you see the contrast, you know that's not in the right place. So this is where we can prove that this injection, we were too anterior, going right up to the aorta. Luckily, we didn't make another error of that bad judgment, and it kept going. We pulled back, and we took this fluoroscopy, and we can at least show that this was not in a good position. So then we went ahead. Now you see that we're in a different position. So having something there as a landmark can help you to know your adjacent anatomy. All right, beware of the aorta anteriorly and the posterior LA borders. Always important. Here's another one. Here's an angiogram of the aorta. You notice that I think we're supposed to do a stent of the outflow tract, and we notice this vessel here. And in fact, we have to understand the coronary courses. So you have to make sure you understand the coronary course relative to where you're going to stent. So in fact, if you look at the lateral, this vessel is right, it's the same vessel there. Imagine we're going to put a stent right here. What do you think is going to happen to that coronary? So again, know your adjacent anatomy to where you're going to put devices. Here's a patient who had a partial veins repair, and this is post-op. You know, there's a stenosis. Now, plan was to go ahead and stent this. Now, you know why we have to think about what you have to think about. You know that the pulmonary veins was right there during surgery. So if you're going to stent this, what could you do? You can compress the pulmonary vein, which is actually worse, right? So what you have to do is think about that. Know that in advance. We did a transeptal puncture, took a picture. Here's the veins. It's right next to that stenosis. Now, you have to ask yourself, if I inflate a stent there, am I going to obstruct this? I don't know that, so I'm going to do a balloon test it to make sure it's okay first. In this case, if we inflate the balloon, we notice the waist is right here. Take another picture, and you notice that the vein is not compressed. It was close, but the stenosis is right here. So with that, we knew we have confidence to go ahead and stent it. If this was right underneath, and this had an obstruction with this indentation, we wouldn't have put a stent in. So then we put the stent in, and in fact, after we stented it, we took another picture just to prove to ourselves that there's no obstruction. So again, you gotta be aware of the adjacent anatomy. Here's a picture of the device sitting in the ASD. Looks really good, but I wanna point out to you that the movement of the device compresses into the aorta, and sure enough, this is what happened. Look at it, huge effusion. All right, and in the OR, you can see this laceration. So again, got to know the device and its adjacent anatomy. You kind of familiar with all the different problems with ASD devices, because I know a lot of people here implant devices, but understand the adjacent anatomy well. Here's another example. This kid had a LeCompte maneuver, had stents put in, and after we further dilated, we took a picture. What's wrong with this picture, guys? see anything wrong?
Frank, 1 minute.
Oh, sorry. I'm sorry. I'm almost done, promise. So you notice there's some contrast here. That tells me that there's something wrong here. That tells me there's some unopacify blood going into mixing with the contrast here. So of course we go in and take a picture in aorta, and what do you notice? You notice contrast right here. A little bit up there. And in fact, you see a little bit of contrast coming through here. So we know we created a dissection between the PA stent and the aorta. Luckily, we have covered stents now, so we can cover it and get ourselves out of trouble. So make sure you have these things around to get yourself out of trouble. All right, so this is, again, in a Lecoq maneuver, you can picture how we can indent the aorta. So this is got to be very important. In Lecoq maneuvers, you got to be very careful about stenting the pulmonary, especially if it's bilateral. If it's unilateral, it can shift to one side, but if it's bilateral, the aorta has no place to go. All right, so respect calcium. Sorry, I'm gonna bypass this. Okay, I'm sorry. So I'm gonna get rid of this, but again, just respect calcium. Again, as I said, either you win or the calcium wins, and both you lose, no matter which way. So always pay attention to. And this is an example where we put bilateral stents in, and in fact, eventually we were able to get it out. But this is my former surgeon, Dr. Bichelle, took this out and gave it to me to show me what those calcium look like. They look like very sharp spicules. If you ever stick your finger into a pipe that's old, you feel it, it's very rough. That's the calcium that's sitting in those conduits. So respect calcium. All right, I'm summarizing here. There are real risks and complications associated with cardiac catheterization, but overall the risks are quite low. Treat each patient according to his/her unique anatomy and physiology. Anticipate and monitor for potential problems. Communicate to your team, especially surgeons. Expect the unexpected. Plan for and prepare to handle complications. Details, details, details. It's the little things that can help or hurt you. When the complication occurs, stay calm. I think I said that several times. Think and stay with your role. Get help and work as a team. You are responsible for the lifetime of the implanted device. That's why it's not over even after it's over, because you're going to be responsible for that. Get very familiar with retrieval devices. Don't let a complication discourage you. Accept the mistake and don't point the finger to somebody else or act of God. It's your mistake, but learn from it so that you can get better. Thank you.